And the trauma sometimes and typically is not evident, it's sometimes hidden. And this brings up to the phenomenon of traumatic dissociation. And traumatic dissociation is just characterized that there's something hidden and we try to push it back and we put sand and beton concrete on it because it's so heavy and so horrible, but it will come up. And this is the therapeutical work that we have to do, and these are the people in the blue overalls, that these are the therapists and the patients, and we both have to dig in the shit and have a look at it. And this is therapy. And this is very, very demanding for the patient and also for the therapist. And the therapist also can get traumatized by that work. I know that an EMDR therapist or trauma therapist, they have really hard, challenging situations, and they have to be careful not to be traumatized secondary from the work they do. Because this is heavy what these people do. This is the author I like really a lot, Judith Herman. She's writing about the dialectic between avoidance and intrusion, and this can be observed not only on the individual level, but also on the societal level. This book, Trauma and Recovery, was not translated into French. This is for me very revealing that this book was translated in so many languages, but not in French. And in French psychotherapeutical culture, there's quite a lack of this knowledge, how it was described in that book. And this is certainly things you have already heard, and in other epidemiological studies about trauma, these are typical numbers we have in the big surveys from the United States that show, and this is the important thing, these things occur during the young age already. The evidence of trauma is not something that is primarily adults have to deal with, but the big problem is children and teenagers have to deal with it. And it's really high. You have any traumatic experience, and these are not little worries. These are big things that just happen. Are to about 40% of the population before the age of 13. And sexual violence, it's about 10% before the age of 13. And then, of course, 13, 14, 15, 16 youngsters, they still have to face to other incidents of traumatic experience. And I show the first picture up there is this. It seems to be it's a natural disaster catastrophe with victims, and the lower one is interpersonal violence. Both can lead to traumatization, but I think the most important ingredient to make out of a potentially traumatic situation, a post-traumatic disorder, is the reaction of the social compound. If the people are taken care of, if someone is taking care of these, the relatives of these people that have lost people, the injured one, the homeless one, or if someone takes action to protect that boy, the boy will not develop a post-traumatic stress disorder if someone is caring adequately. But the problem is in our society, we have a culture of neglect, and we do not care appropriately. We let people alone, especially children, but also adults. And this is what makes a trauma becoming a post-traumatic stress disorder, because there was no appropriate reaction from the side of the people responsible to interact. I think this is, for me, very important to stress, because I see in my treatment that the patients are shocked more by the absence of care and protections than by the aggression many times. So it's important there is always a social compound when there's a trauma within the social network. And this is true also for natural disasters, when people are let alone after catastrophe. And maybe you have heard from the studies of Noemi Eisenberger. She examined what is happening in the brain of a person when she is rejected, or if she is in grief, or she is reminded of a very difficult breakup of an emotional relationship, loss of relationship, all these difficult human experience, in the relationship, how does this is perceived in the brain, and what she was able to show, that the same brain areas are activated like in physical pain. So it's important that there's the equivalence of social and psychological painful situations and having a broken arm or leg. This hurts in the same area in the brain. You see here the insula, the AEs in the insular cortex, and the DACC is a part of the cingulate cortex in the frontal lobe. And these are typical areas that are related to coding pain. And the pain is regardless of it's a broken arm or it's a broken relationship. So we have an alarm system in our body that is not only coding for loss of a vital organ, but it's also coding for loss of a vital relationship. And we are human, we are social animals. So if we lose connection, this is very painful, and this is coded as being very dangerous. And this is, in my opinion, what happens in psychiatry. Our patients are people that have lost connection. And this is another study that is very important to cite. It's the ACE study, Adverse Childhood Experiences. And this is in addition to what I showed before. The other was single difficult or incidents, like an accident, someone died, or maybe there was an assault. But this study, they focused on repeating stress. And also, as you see, before the age of 18 in this case, the ACE study, before the age of 18, what happened to these people as repetitive stress during growing up. And there are 10 different criteria: neglect, mistreatment, and household dysfunction. And this is all situations that are not, as I said, not just once, this just happened again and again. Like when one parent was alcoholic, one parent was had a psychiatric disorder, there was repeated neglect, this kind of stuff. And if you get to these numbers, then it's quite shocking. Then you see only 32.7% of the population have the chance to reach the age of 18 without having to face any of these stress factors. Only 1/3 of normal people in the United States that are rather belonging to the higher class, because they were all in health insurance, these people. So they're rather in the higher economical class, and only 1/3 arrived at the age of 18 without any major repetitive stress, which does not mean that they might not have another stress that was revealed in the other study. It's complementary. So there's a very high prevalence of traumatic stress in the population, in the general population. And what is most shocking, if you can also sum up these scores, that's 0, 1, 2, 3 of these factors up to 10. And we see, this is the other number here, that 10.5 of the general population had to face 5 or more stress factors during childhood and adolescence. That's enormous, 10%. And then if you do the correlations between these stress factors and other medical problems or social problems later in life, and this is a follow-up branch of that study. They followed the people. How were they evolving with all that stress? And there's a clear positive correlation between the more you have dealt with stress, the more you are vulnerable later in life to have all kinds of problems in psychiatry, with addictions, but also with somatic disease, autoimmune diseases, hypertension, cancer. All this is related to stress exposure during childhood and youth. And you do this with drug abuse, and it's really highly significant. And this is confirming my hypothesis that all drug addicts they have been traumatized. And sometimes they cannot even remember it because it's hidden in dissociation. And I'll come to this a little bit later. So I like a lot this conclusion of this book from Rougemont-Bücking. This is an excellent book. It's resuming all the evidence for the effects of trauma in the society and on the individual. And I really like the subtitle, which is the hidden epidemic. because it's so obvious that it's so important and we do not talk about it. We pretend that trauma is rare. And we pretend that psychiatric disorders are metabolic disorders of the serotonin system in the brain. This is the current explanation I heard so many times in my training, yes. This regardless of the evidence that was brought up by science. And this is an old problem that's not new. If you see the debate between Pierre Janet and Sigmund Freud, what is dissociation? What is trauma? What are post-traumatic disorders? And Janet was putting in front his interpretation of scientific evidence, because they all studied the subjects in the Salpêtrière, and he came to the conclusion dissociation is lack of integration. And Freud, who studied the same subjects, came to the conclusion that dissociation is a form of psychological resistance. What does that mean? We will talk a lot about, I will explain a little more about the idea of dissociation as a lack of integration. And the dissociation idea of being a psychological resistance is just an explanation of that the victim or the person has rather a fantasy that is of sexual or aggressive content, and the problem is arising how to deal with this fantasy and how to resist against this fantasy. But the question of the trauma occurred, yes or no, has no importance. So this is a difference that Gianni really said that the lack of integration is just the fact that the organism cannot deal with that occurrence, and it cannot deal with it, so it has to put it somewhere in the drawer of dissociation, and then it has a hidden life. And Freud rather said, no, this is the rejection of the subject that does not face to have aggressive or sexual fantasies about the parents. But this is, with the regard from a traumatologist, this is just absurd to claim that the problematic of a patient comes from aggressive or sexual impulses against the parents. As we know, the parents are abusing and beating the children and not the other way. So it's very important to realize, for me, this is very important what I'm saying, because there was a scientific evidence. Freud and Janet, they examined these women, and they both came to conclusion there's something about trauma. And hysteria has to do something with trauma. And they come to different interpretations of evidence. And I think we should be aware of this, that we have scientific evidence here now as well. And what is the interpretation we're doing as scientists? What are we telling ourselves and society about what we have found out? And I think it's very important to remind what happened between Janet and Freud. And they were both students of Charcot. And they were both very ambitious physicians at that time, especially Freud, because this was the major public health problem of the 19th century, hysteria. And we are also today facing, as scientists and therapists, the major public health problem of our time, which might be depression or burnout or drug addiction. And we also are struggling to find explanation that we might explain to the public. And we may also explain this to the people that give us money to do research. And I think we have to be aware of the biases that we carry as therapists and also as scientists to give an explanation to the public about the evidence that we perceive of trauma within the population. So I think we can learn a lot from that debate about hysteria and about many other traumatic disorders like shell shock, the soldiers of First World War I. There was a whole debate, what is this about? And I think we are really in a difficult position as scientists to bring up conclusions, explanation to the public that is socially acceptable. And the Freud hypothesis of the Oedipus complex, where the child has sexual urges and aggressive urges against the parents, and this is the core of the problem, is still very much presented in the public and also in many therapists and also in the scientific world. Although we know today that this is wrong. The child did not rape the parent raped the child. This is a fact. This is what we hear from the patients. So we have to be aware that there are huge interactions between society that only can accept certain explanations. If Freud had said, which he did first, at the bottom of hysteria is a sexual trauma. That's what his first publication, 1896, so Étiologie de Hystérie. And when he published that, there was total not acceptance at all from the peers of this kind of claims. So he modified it and he developed then later the Oedipus hypothesis of that, what happened to that woman. So it's, for me, why I say that it's very important that we are aware how we deal as scientists and therapists with the evidence of trauma and what kind of interpretations we present to the public. And I think the psychedelics bring this to the very upfront, that we have to deal with the occurrence and the evidence of trauma, because this is coming up in therapy so much. So this is the model of normal integration. In orange, you see this is the working memory, central executive. That's how you think about what's happening right now. Thinking, and you put your attention to the future or to the past. You're able, especially, these are the green arrows, you go to the past and you look for specific information. This happened to me, this person I know, this is this and that, this means this and this. So you can deal with the present situation and you can anticipate the future. But you can walk around your consciousness quite freely. This is the ideal of normal integration. If you have a traumatized person, we get something quite different. We see that the energy, the amount of thinking that is available for thinking, the present, the working memory, it's much reduced because it has to deal with something coming from the past. It's kind of an intrusion. It lays heavily down on the working memory, and the problem is people cannot actively go into that. They cannot look for specific information. Whenever they try, that's the green arrows, it's blocked. They cannot go on. This is so typical. If you ask people for difficult experience in the childhood, often they will say, "I don't remember anything." This is traumatic dissociative amnesia. This is the rule. This is not the exception. This is normal. People cannot remember because I remember Yanni. Trauma is defined as overpassing the integrative capacities. And as long as it's overpassed, people cannot remember. But the symptoms are still there on the bodily level. And the symptoms, they manifest with the flashes as intrusions. The intrusions can be a sudden pain, a panic attack, or it can be automated thinking, I'm bad, I'm ugly, I'm guilty. These are automated intrusion that comes from the trauma, from the abuse. And this is totally uncontrollable by the subject, and the subject really has to spend lots of time and energy just to contain. And also the person might use substance like alcohol to calm this down, because it's very heavy to carry. And these people have very little energy to anticipate the future. They're really stuck, and they have to carry this trauma. And traumatologists, they call this part that is from the past that is not accessible, but it's intruding. They call this the emotional part, la partie émotionnelle. And the other part that is dealing with the daily life, that is going to the doctor, that having a coffee with friends, working. This is the A and P, this apparently normal part. And we think, in our classical psychiatric paradigm, we think A and P that is well adapted to society and is making money and paying the bills is a good person. That's what we claim. And therapy is supposed to bring people to have a well-functioning A and P, to adapt well to society. So the problem is that A and P is considered to be healthy in this regard. But if we have a look at traumatic dissociation, we realize that A and P is not healthy. It's only apparently normal. It's just surviving, helping the whole system to survive. And it's also fueling the antagonism and to strike back the EP, the emotional part that always popping up, like a ghost. We have this idea of ghosts that are hidden in the basement and they come up, and A and P always try to hold that back. And this is how the many people, traumatized people, work in daily life. And the problem with classical psychiatric paradigms, I see many times that we are just dealing with A and P and trying to build up A and P, and we call these are the resources of the person, but we are not aware. The more we do that, the more we sustain also traumatic dissociations, because the other part, the EP, is excluded from the therapy. And this is a very problematic setup. So these are the works from this Dutch specialists, also American specialists, I really appreciate a lot. The livre en français, Le Soi hanté, The Haunted Mind, The Haunted Soul, I think in English. Very interesting. And it's really, for me, it's crucial for a psychedelic therapist to have a good knowledge about this. But because this pops up in therapy repeatedly, regularly, that all of a sudden the EP is coming up, and the EP is defined, it's stuck in the past. The EP has not yet realized that the threat and the trauma is over. This is typical. And when you give psychedelics to these people, all of a sudden there's a little child talking to you, is in anger, is traumatized, is full of fear, and this is just happening. And you have to be able to read that and to interact with that. And especially, this is very challenging if the people, the children, and have to adapt to repeated mistreatment, because this brings the person to identify with the aggressor, with the perpetrator, in order to survive. This is a typical situation of captivity, where there's no escape possible and you have to adapt with the perpetrator. Like in the case of Natasha Kampusch, then she was secluded and she was dig down deep in the basement, and whenever the perpetrator, Wolfgang Priklopil, whenever he left to go to work or to go shopping, she was afraid and she was praying for him to come back, because her life depended on that man. So this is explaining why a victim of chronic mistreatment develops a very strong bond with the perpetrator and identifies also with some of the values and the way of interacting in order to survive. Because if the victim goes into opposition, the victim will not survive. So the victim has to submit and identify with it in order to survive. And this is something you can observe in the individual, but you can also observe this in societies. A mistreated society, you will observe that people are identifying with the logic of power, because their survival depends on that. And we call this Stockholm syndrome. And this is very, very frequent. It's not rare. And in my opinion, that's why I do research on burnout. This is also totally what's happening in the workplace, because people have to work to pay their bills. And they adapt and accept things that are against their values often. This is moral injury. And they continue and continue until they just cannot go anymore. This is, for me, adaptation to trauma, chronic mistreatment, burnout. That's what I try to investigate in my research. So captivity brings up to traumatic attachment, identification of the perpetrator, and this is the most difficult part to treat. So these are the important alterations that you can find in traumatized persons. I don't go to the hard words so much, all the things you know, the modification of the immune response, the stress response of the body. I go mainly to the three big challenges for therapists is the phobic avoidance of the traumatic memory. It's the thing what I explained, this wall from the EP, you cannot go through this because it's too painful. This is what brings up clinically as phobic avoidance of the traumatic memory. The second is the deficit of contextualization. I will explain it to you. And the last, the most difficult one, it's traumatic attachment in the relationship. And this is something you cannot treat with substances. You only can work on this in the relationship. So this is, in my view, these are the clinical problems of complex PTSD patients. Phobic avoidance of traumatic memory. This is, I will show you, when the amygdala rises up, and as soon as you go into the difficult memory, the traumatic memory. And this you can overcome very good with MDMA. So I think MDMA is a very precious substance in order to go in direction of the trauma, the traumatic memory. The other problem is the deficit of contextualization. That means the EP, the traumatic part, it still is convinced to be in the situation of mistreatment, of threat, now. So the context of now, in which the ANP is living, has not yet reached the consciousness of the EP. The EP is stuck in the past, in the context of the past. So this is a deficit of contextualization, which can be overcome, in my opinion, very well with classical psychedelics. Because what is the psychedelic experience? It's just a confrontation with the context of here and now. And the last, the traumatic attachment, this is, in my opinion, something, this is just the whole that you have to be present in the relationship in order to bring the person out of this traumatic attachment to abuse. You have to show the patient ways to get out of this identification. This is only possible when you are present as a human being and showing there are other ways of interacting. This is very challenging. And on the neuroscientific or biological level, there are phenomena like fear extinction learning that I find very interesting to study. Also in the animal model, in my opinion, that is. And of course, what is very interesting in trauma therapy, all this idea of memory reconsolidation. You activate the memory, you go with it, and then you can modify it. And this is also what's happening in the psychedelic sessions. But the most important tool in all that is this therapeutical integrity of the therapist. It's never the substance that doing that alone. You have to be present, and you have to accompany this shaping, new shaping of synaptic plasticity in the relationship. That's so important. It's not the substance doing that. It's opening the gate, but you have to work then with it.